Hello, my dear brothers and sisters. Today we are talking about retropharyngeal abscess. So the retropharyngeal abscess is a is an abscess. So here we have it is presented by Dr. Parvez Ahmad Rishi and um, deep spaces of neck. Today we are going to start with deep spaces of neck. We can see that the deep spaces of neck are submandibular space. This is the submandibular space. You can see this is the submandibular space here. And now this is the peritonsillar space. So this is the peritonsillar space. You can see here peritonsillar space, the space around the tonsil. Okay, this is the peritonsillar space here. Then we have parapharyngeal space. This is paired space, this is parapharyngeal space. Okay, so if you remember parapharyngeal space, it is surrounded by four other spaces. This parapharyngeal space is surrounded by four other spaces. Now the first space is the retropharyngeal space. This is the retropharyngeal space. This is unpaired space, retropharyngeal space. This is the pharynx, it is just behind the pharynx. So the prevertebral space, now this is the prevertebral space. You can see here prevertebral space. Here you can, so you can here I will see the color retropharyngeal space. This is the retropharyngeal space, yellow one. And then we have masticated. This is the rams ABCD. We have prevertebral space is the this one. This is the vertebra, and this is the prevertebral. This space is the prevertebral space, and this is the alar fascia. This is the alar fascia surrounding the prevertebral space, surrounding the prevertebral space. Okay, now the space of danger, it is here. This is the space of danger on both sides. This is the space of danger where these two spaces, the parapharyngeal space and the retropharyngeal space, where they meet, they form this, that is the place where the space of danger occurs. Okay, parotid space. Now this is the parotid space. This is the parotid gland, that is where the parotid gland lies. This is the carotid space where the carotid artery and other. So carotid space, parotid space, masseter space. You can see the masseter space, masseter space is there. And now this A represents the ramus of mandible, and B represents the masseter muscle. B represents the masseter muscle, this one. And C represents the medial pterygoid muscle, and D is the alar fascia. D is the alar fascia. So we have learned that this is the parapharyngeal space, and then we have the carotid space, we have the parotid space, we have the masseteric space, and we have the peritonsillar space here. We have submandibular space. This is the submandibular space, submandibular space here. This all area is the submandibular space here. This is submental space. This is submental space. Then submaxillary space is also there. Submaxillary space. And this space, this is the sublingual space. This space which it shows is the sublingual space. So you must go through these spaces and have a good idea and try to learn, make these diagram. You must be able to draw this diagram, only then you can appreciate. Now we have retropharyngeal space. It is a connective tissue between the buccopharyngeal fascia and prevertebral fascia. Buccopharyngeal fascia, this is the buccopharyngeal fascia. Okay, this is the buccopharyngeal fascia. And prevertebral fascia, this is the prevertebral fascia. So the space, the retropharyngeal space is the space between buccopharyngeal fascia and prevertebral fascia. The two fascia are attached to each side by median raphe. They are attached by median raphe. Median raphe. This is the pharynx, and this is the buccopharyngeal fascia. This is the prevertebral fascia. In between, they are connected by median raphe, and this space is called the retropharyngeal space. It extends from cecal base to the posterior mediastinum. Cecal base to posterior mediastinum. It contains retropharyngeal lymph node, one on each side. It contains retropharyngeal lymph node. This is what is this retropharyngeal lymph node? Retropharyngeal lymph node regresses at the age of 5. After age of 5, this lymph node doesn't exist. It regresses. So usually the abscess occurs before age 5. Okay. Retropharyngeal abscess. It is acute retropharyngeal abscess, and we have now to discuss acute retropharyngeal abscess, commonly seen in children below 3 years of age, results of separation of retropharyngeal lymph node of Rovenier, secondary to the infection in adenoids, nasopharynx, paranasal sinuses, or nasal cavity. So what are the neighbors of this node of Rovenier? Node of Rovenier, it has 5 neighbors. Adenoid is one neighbor, so infection comes from adenoid. Adenoid lies very close to nasopharynx, so nasopharynx is another source. Paranasal sinuses is another source, and nasal cavity is another source. In adult, results from penetrating injury of posterior pharyngeal wall or cervical esophagus. If there is penetrating injury of cervical esophagus or posterior pharyngeal wall, then this may occur. Okay. Retropharyngeal abscess. So now we are talking about retropharyngeal abscess. So this is the retropharyngeal abscess here. It is the graphical representation of retropharyngeal abscess. This is the alar fascia. We told you about alar fascia, and in the coming slides we will discuss about alar fascia. It is very important. This is peritonsillar abscess. This is the peritonsillar abscess. This is the retropharyngeal abscess, and here you can see this is the wall of pharynx. Don't get confused. This is the picture. Before this, we had pictures which were upside down. Now this is the picture which is upside down. Okay, ramus of mandible, and this is medial pterygoid, this is masseter, this is parotid gland. That is how he has given it, retropharyngeal abscess. Now you can see here, we can see this is the uvula, this is the soft palate, this is the tonsillar fossa, this is the tongue depressor. Here's police the tongue, this is tongue, these are the teeth. And what we have seen, this is the posterior pharyngeal wall, and the abscess lies behind that wall, so there is a bulge and redness here, so it may be retropharyngeal abscess. Now again, we have here the clinical features: dysphagia. There is dysphagia, difficulty in breathing, stridor, croupy cough, torticollis. On examination, bulge in the posterior pharyngeal wall usually seen on one side of midline. There is a bulge on one side of midline. Radiography, soft tissue lateral view of the neck, widening of privatible shadow. I will come to that. And sometimes presence of gas. There may be gas present. Treatment is incision and drainage, systemic antibiotic, and we may need tracheostomy. So we may need tracheostomy, we may need incision, we may need antibiotic. Incision, antibiotic, tracheostomy. We have dysphagia. The signs are dysphagia, breathing difficulty, stridor, croupy cough, torticollis is neck like this. Okay. So on examination, there is bulge in the posterior wall. Radiography, there it shows soft tissue lateral view of the neck. Widening of privatible shadow. Sometimes presence of gas. Okay. Retropharyngeal abscess, chronic retropharyngeal abscess. Now we were discussing acute retropharyngeal abscess. Now come to chronic retropharyngeal abscess. It is tubercular in nature. Chronic retropharyngeal abscess is tubercular in nature and is a result of caries of cervical supine. Tubercular infection of retropharyngeal lymph node, secondary to tuberculosis of deep cervical nodes. Caries of cervical supine represent centrally behind the privatible fascia. Caries of cervical supine, and it is like this. Tuberculosis of retropharyngeal node. There may be tuberculosis of retropharyngeal node limited to one side of midline. It may be limited to one side of midline. Okay, chronic retropharyngeal abscess. Number one, remember tuberculosis carries of cervical supine, tubercular infection of retropharyngeal lymph node, secondary to tuberculosis of deep cervical nodes, caries of cervical supine present centrally behind the peritoneal fascia, tuberculosis of retropharyngeal node. Okay. Retropharyngeal abscess clinical features discomfort in the throat, dysphagia on examination, posterior pharyngeal wall shows a fluctuant swelling centrally or on the side of midline. Neck may show tuberculosis lymph nodes. X-ray lateral wave neck is diagnostic of caries. Supine treatment is incision and drainage. Antibiotic and anti-tubercular therapy. Anti-tubercular therapy. So we give anti-tubercular therapy. We take X-ray and the diagnostic of caries of supine. We take X-ray and on the X-ray we find caries of supine. What do we find on the X-ray? Caries of supine. What treatment we give? Incision and anti-tubercular treatment for chronic retropharyngeal abscess. Investigation is CBC, it will show high WBCs, X-ray, and it will show neck and X-ray neck and chest. We say USG, ultrasound of the neck, needle aspiration and culture sensitivity and CT scan. We have treatment, education, educate the patient and take consent for surgical interventions that may arise. Airway management, IV antibiotic, penicillin, sulbactam, clindamycin, ceftriaxone, metronidazole, surgical drainage treatment. Surgical drainage is done under GA, intubation, oral intubation, fiber optic intubation, and tracheostomy under LA. Transoral or transcervical approach. Transoral, transcervical approach. Supine and extreme Trendelenburg position, posterior pharyngeal wall, transoral approach of retropharyngeal abscess. Transcervical approach of retropharyngeal abscess, low abscess along anterior border of sternocleidomastoid muscle. Transverse cervical skin incision is given, raising subplatysmal flaps to expose the neck and dissecting along the anterior border of the sternomastoid. The sternocleidomastoid muscle and carotid sheath are then retracted laterally. Blunt dissection is done up to level of hypopharynx. The retropharyngeal space abscess, deep drainage placed and maintained. So we have transcervical approach of retropharyngeal abscess. We go transcervically. Low abscess, if there is abscess is low, so we go transcervically along anterior border of sternocleidomastoid muscle. Transverse cervical skin crease, we give transverse cervical skin is given, raising the subplatysmal flap to expose the neck and dissecting along the anterior border of sternocleidomastoid. The sternocleidomastoid muscle and carotid sheaths are then retracted laterally. Blunt dissection is done up to the level of hypopharynx. The retropharyngeal space abscess, the blunt dissection is done up to the level of hypopharynx. Deep drain placed and maintained for 5 days. We keep the drain. High abscess, it is along posterior border of the sternocleidomastoid. We have low abscess, we discussed it in the previous slide. Now we have the high abscess. The high abscess is along the posterior border of sternocleidomastoid. This is the retropharyngeal abscess. It is on the along the posterior border of SCM. So you can see that how we approach it and how we high abscess along posterior border of sternocleidomastoid. So parapharyngeal space. Now let us go to parapharyngeal space. Para means on the side, on the both the sides of the parapharynx, on the pharynx, which is a single tube. It has on both sides. It has a space that is called parapharyngeal space. And parapharyngeal space communicates with 4 other paired spaces, which I will come. Base is base of skull and apex is higher bone. So it is apex is higher bone and its base lies on the base of, it is an inverted pyramidal space. Anterior pterygomandibular reef Anterior is pterygomandibular rib, posterior is privatival fascia, median is buccopharyngeal fascia, retropharyngeal fascia. So buccopharyngeal fascia and retropharyngeal fascia. Again, and then lateral parotid gland, ramus of mandible, medial pterygoid, and masseteric fascia covering posterior belly of digastric muscle. So we have, this is the space. Now we have privatival space. This is the privatival space. We have cranial nerve 9, 10, 11 in nearby here, 11, 9, 10. Then we have the parotid gland. This is the parotid gland, and retropharyngeal space. This is the retropharyngeal space at the back of pharynx, and this is the medial pterygoid muscle. This is the masseterial muscle. Okay, then this is the privatival fascia. Before the vertebra, this is the alar fascia. Okay, this is the danger space. This space is the danger space. This is the retropharyngeal fascia. Retropharyngeal fascia. This is the retropharyngeal space. This space is the retropharyngeal space. Okay, retropharyngeal space. This one retropharyngeal space. And so we have, okay, parapharyngeal space. This is the parapharyngeal space. So we learn that the base is on the skull base and apex is on the hyoid bone. Anterior pterygomandibular reef, pterygoid and mandible, pterygoid and mandible, pterygomandibular reef. Okay, parapharyngeal space, parapharyngeal space. This parapharyngeal space. So we have medial buccopharyngeal fascia and retropharyngeal space. Buccopharyngeal fascia. Buccopharyngeal fascia. This is posterior. This is medial buccopharyngeal fascia, and this. What is this? Buccopharyngeal fascia. Parotid gland, ramus of mandible, lateral parotid gland, ramus of mandible, pterygopalatine, pterygoid muscle, fascia covering posterior belly of digastric. So this is the lateral, this is the medial. Okay, this is the lateral, medial, and then we have anterior is pterygomandibular reef, pterygoid and mandible, pterygomandibular reef, pterygomandibular reef, pterygomandibular reef. This is parotid space. Okay, okay, now let's go to another slide. We will come back. Parapharyngeal space. So where is the parapharyngeal space here? Parapharyngeal space. This is the parapharyngeal space. Okay, parapharyngeal space. Now you can see this is submandibular space, this is submaxillary space, submandibular space, submaxillary space. Okay, this is sublingual space. This space, it is this space, this is lateral pharyngeal space and retropharyngeal space. This is the retropharyngeal space. This is the danger space. This is the danger space, space of danger. This is the masticator muscle. This is the masseter muscle, pterygolateral pterygoid masseter muscle. Parotid. This is the carotid space. This is the parotid space. Okay, this is the lateral pharyngeal space, or this is parapharyngeal space. It communicates directly with other deep spaces, include the retropharyngeal space. It communicates with retropharyngeal space. Here you can see the arrow communicates with retropharyngeal space. Submandibular space communicates with the submandibular space, and carotid sheath, it communicates with the carotid sheath. Okay, these are the spaces around. So don't worry, this is the parapharyngeal space or lateral pharyngeal space on the lateral side of the pharynx. So this is the retropharyngeal space and the back of the pharynx, and these two spaces communicate. This parapharyngeal space also communicates with the carotid sheath. It communicates with the submandibular space, sublingual space, with the retropharyngeal space, and parotid space. Parapharyngeal space, it is divided by styloid process and its attachment into the prestyloid and post-styloid space. Prestyloid space contains parapharyngeal fat, lymph node, and deep lobe of the parotid gland. So prestyloid process, prestyloid part of the parapharyngeal space, it contains deep lobe of parotid gland and parapharyngeal fat and lymph node. Post-stellar space contains the internal jugular vein, internal carotid artery, cranial nerve 9 and 10, 9 and 10, and 11 and 12, sympathetic trunk and superior sympathetic ganglion, ascending pharyngeal artery and lymph nodes. So, Parapharyngeal abscess etiology. Pharynx is acute and chronic infection of the adenoids or tonsil, bursting of peritonsillar abscess, teeth, dental abscess, lower last molar, ear is bezold abscess, peritonsillitis, and infection of parotid, retropharyngeal, and submaxillary space, and penetrating neck injury. Did you get it? And parapharyngeal abscess etiology. Parenchyma acute and chronic infection of adenoids. So etiology is that is adenoids which are nearby neighbors. If there is infection of adenoids, we may get parapharyngeal abscess, bursting and peritonsillar abscess. We have teeth, dental abscess, and we have bezold abscess and petrositis. Bezold abscess comes from the neck, and parapharyngeal space, infection of parotid, retropharyngeal space, and submaxillary space, and penetrating neck injury may be another cause. Parapharyngeal abscess, it is clinical features, external swelling behind the angle of jaw. Swelling behind the angle of jaw, prolapse of tonsils and tonsillar fossa, prolapse of tonsils and tonsillar fossa, trismus, paralysis of cranial nerve 9, 10, 11, and 12, swelling of parotid region, and fever, sore throat, odynophagia, signs of toxemia. Signs of toxemia. So these are the features. There is trismus, there is paralysis of cranial nerve, there is swelling of parietal gland, there is fever, sore throat, odynophagia, signs of toxemia. So how we treat it? How we treat it? We treat it by giving them in incision and drainage, external drainage, systemic antibiotic analgesic. We give incision and drainage. Parapharyngeal abscess drainage, transoral approach. We can give orally. Now the patient is lying down. We have used the Draftness bipod. We have used the wild ass mouth gag. Indication for abscess located medial to greater vessels. If it is medial to great vessels, patient places supine in Trendelenburg position and mouth gag is used. Parapharyngeal abscess drainage. Parapharyngeal abscess drainage. Palpate the swelling to localize the abscess. Insert 14 gauge needle and aspirate. Aspirate pus should be sent for culture. Vertical incision given in the fluctuant area over mucosa only. Long clamp used to dilate the opening and allow for further drainage. A rubber catheter attached to 60 cc syringe can be employed to irrigate the cavity. The incision remains open to allow further drainage. Suction must be at hand. Parapharyngeal abscess drainage. After securing the airway, patient placed in supine position with shoulder roll, head turned to collateral side, and incision 2 to 4 centimeter in length is drawn approximately 2 fingers breadth below the inferior border of the mandible on the affected side. Master tip, this is the master tip, this is the lower border of mandible, so this is the incision line, but usually we don't need to give such big incision unless we are doing in GA. Infiltrate with lidocaine and adrenaline the neck face up to the oral commissure and shoulder or prepare or prepped. The patient is then draped, exposing the neck, clavicle, earlobe, and midline neck and the oral commissure. The skin and subcutaneous tissue are then sharply incised. The platysma can be incised sharply with or electrocautery. The submandibular gland should be identified and dissected along the inferior border. The gland and its overlying fascia can then be retracted superiorly and protecting the margin of the mandibular nerve. Next, the anterior border of the sternocleidomastoid muscle and great vessels are retracted posteriorly. The great cornu of the hyoid is a particularly important landmark to identify next ones. Identify the posterior belly of digastric muscle should be apparent. The surgeon's finger can be used to bluntly dissect along the medial border of the posterior belly of digastric muscle towards the styloid process, sickle base. Blunt dissection is continued to break up any adhesions remaining loculations. Abscess is drained, wound bed is copiously irrigated with at least 1 liter of warm saline. A drain should be placed into the abscess cavity and exit the excision. Excision partially closed leaves the opening of the drainage. Acute laryngeal edema. Complications are acute laryngeal edema, thrombophlebitis of jugular vein, retropharyngeal abscess, mediastinitis, erosion of carotid artery. Principles of neck abscess drainage. Ensuring secure airway is the first priority in the management of a deep neck infection. Therefore, intubation with dissected laryngoscopy or tracheostomy should always be considered. So, the important principle of surgical drainage of a deep neck abscess is wide exposure. Identify the landmarks. Blunt dissection should be used whenever possible. Identifying the carotid sheath early is crucial for avoiding inadvertent damage to it and to the major neurovascular structure it contains. The abscess should be completely drained and include blunt avulsion of any loculations. Thank you very much. Please go through my other videos and like and subscribe the channel. Thanks a lot. Thanks for your time.